sports and exercise, as well as digital therapies. This guideline has now been published. It's available in English or also as a short version in the world well-known journal World Psychiatry, and has been published 5 months ago. So you see now, mindfulness has the highest form of evidence for treating positive symptoms in psychosis. But this has not been always like this. When I started to research mindfulness, together with Tamta that you have known already, or Eric Hahn that many of you know, and many other people I would need to mention at the Charité in Berlin, we asked ourselves why in Germany no one is giving mindfulness therapy to psychosis. And we looked into the literature and we found out that in the UK and in Australia, there are already a couple of studies in this field, but none in Germany. In Germany, many people still say if you do mindfulness with people with psychosis, they could get worse. So you ask yourself, how does that come? And we wrote this editorial, and it asks, is mindfulness for psychosis harmful? And we wanted to deconstruct a myth, because in the 1990s, there were 2-3 case reports where people went into a mindfulness retreat. A retreat is a place you go to 7 days, 14 days, 21 days. It's a monastery where you meditate every day 10 hours. In those retreats, you don't want to have social contact. The people were sleeping only 5-6 hours a day, and they had different kind of food, and they woke up every day at 5 in the morning and started to meditate. And these patients stopped taking their medication before the retreat. So I told you 6 risk factors of getting psychotic. So after this retreat, these patients became psychotic. So people said mindfulness leads to psychosis in schizophrenia. But there is the question of causality. Is this really the retreat that led to psychosis? Or is it not that they stopped medication? They didn't have social contact, they didn't sleep much, but this led to case reports where many people said mindfulness leads to exacerbations of psychosis. Now I come back to my first slide. When we as clinicians use mindfulness in the therapy, it's not a retreat. Patients don't do it for 12 hours. They do it in very short phases, techniques that I showed you. So you embed the therapy into the clinical work. And the question then asks itself, when you do it this way, does it also lead to psychosis? And the evidence says no. And I will show you this. And I want to make you attentive to it, because if we just speak about mindfulness, I don't know what you mean. If you maybe mean a retreat, I would say, oh, a retreat is a challenging place. But a 5-minute intervention with a psychotherapist is something fundamentally different. Why is that important? This is from one of our books. This is a patient that we had at the Charité. And I'm just going a little bit through this quicker. Yeah, but we asked the patient if he wants to take part in a mindfulness-based group therapy. And the patient said, mindfulness is not good for schizophrenia. I heard that it can cause psychosis. So we asked the patient, how does he come to this? And he said, that's what my clinicians told me. This means we as clinicians also give information to patients which is sometimes not evidence-based. Maybe we mean it out of good reasons, but we see that the evidence has changed. So now we introduced the patient to the group therapy, and he took part more and more in those therapies. And we could see that he, for example, does now daily 10 to 20 seconds short mindfulness breath exercises. Not long, not 1 hour, not 3 hours, 10, 20 seconds. And this helped him a lot to observe his psychotic symptoms, and to help to find some calmness. It's not a solution for everything. It is one way, a skill that you can train and cultivate. This is the idea. I will now come to a couple of work from my research group. This is some beautiful work from Sarah Pux and Selina Mavituna. I think Celine is even someone some of you know. So we initially looked now, when you have mindfulness, we saw that it has effects on symptoms. But we asked ourselves, how does this effect emerge? And we found out it has to do with cognitive fusion. So by increasing psychological flexibility, psychological flexibility means the capacity to understand that your thoughts and feelings come and go, that these are passengers, that you are not stuck with your emotions and your feelings. You know some patients who are stuck with the feeling, I am worthless. Yeah? Or they are stuck with the thought, I can't do it. And then they identify with this feeling. They think this feeling is real, but it is just a feeling. Psychological flexibility trains of letting go of these thoughts and feelings. And when you increase this capacity, we find that symptoms go down. And you can train this letting go of feelings and thoughts by cultivating self-compassion. This is therapeutically important. If you increase self-compassion in patients and train with them that they understand how their mind works, that feelings and thoughts come and go, this is how mindfulness has an effect on symptoms. And we could show this in many different studies. This is just one. And we could also show in the large population that this is not driven by personality factors. So if you are very much extroversion or conscientious, doesn't matter. It can still work. Now, I want to do a small exercise with you. I know it is, I think, no more afternoon. It is a Friday today. So my question to you is, what are you planning to do on the weekend? So soon is weekend. I know Vietnam is a beautiful country. What are you going to do in the weekend? Just close your eyes for a moment and imagine what you're going to do on the weekend, what you're going to do today in the evening. And if you say today evening is boring, think about Saturday. What you going to do on Saturday or on Sunday? And then imagine how it will smell when you are doing it, how it will feel, how what you will see. Activate your perception. I'm seeing swimming and sports. Okay, imagine now this moment and you are doing this. Yeah, you are in this moment. And then come back, and it's great that you joined me. Sleep. Okay, this is also a possibility, but this exercise is difficult with sleeping because what I want to show you is, in physics, even Stephen Hawking could not solve the mystery of time travel. But we, in the psych disciplines, we could always do time travel. You traveled into the future through your imagination. You can travel into the past through your imagination. This is a profound human skill. Imagination is a driving force in our life. And why I'm showing you this here? If you activate imagination, you have a mental representation. This mental representation is activating pleasure and motivation. Yeah, you are going today through the day, through the hard work, because on the weekend you will see your friends, you will do sports, yeah? Because you are able to see the future in your imagination, you can motivate yourself. And then by having beautiful experiences on the weekend, you realize this, and this will again motivate you. Maybe you are joining this talk here today because you want to work as a psychotherapist, you want to increase your skills. By imagining this future, you are motivated to listen to this. That's great. Now, this imagination skill, this time travel skill, unfortunately is in patients with psychosis very limited. Patients with psychosis, we showed this in different studies, they want to create these pictures that you have created as much as healthy people, but they cannot create the quality of these pictures. So if I ask a patient, what do you want to do on the weekend? He's telling me many things. He could do that. But if I ask him, how does it feel when you watch football and you listen and you're sitting in the bar, how does it feel? How does it smell? They have difficulties in expressing that. That is a reason why they probably have negative symptoms. We could show that lower mindfulness and lower psychological flexibility is correlated to higher psychopathology. This means therapeutically, from a translational perspective, if you increase the capacity to imagine the future with all the qualities that go with this, you could target motivational processes. And this is what mindfulness can do. If I do a mindfulness meditation and I imagine how my weekend will look like, how it will smell. For example, I watched yesterday football. Did some of you watch football? We have World Championship, yeah? Germany lost. Horrible. Okay, but the Ecuadorians played very good. They deserved it. So I am imagining maybe watching football with my friends tomorrow. I'm imagining how I'm sitting with them in the bar, how the beer will smell, yeah? How it will be to speak with them. This increases the quality of the moment. It activates my senses. And this motivates me to, for example, do this lecture with you today, to later work, because I'm motivated to see my friends tomorrow. Okay. And mindfulness can also be a tool of increasing our senses. And we showed this to different studies. Now, the evidence is very interesting. You see here more than 14 meta-analyses and systematic reviews to the topic of mindfulness. This is very astonishing because we don't even have so many trials in the field. This means that the research field is very much interested in this topic, but not many people are facilitating the therapy. And also here, you see here a very well-known systematic review that says meditation and psychosis, a trigger or a cure. So again and again in this topic, it is always about does mindfulness lead to exacerbation? This is a large meta-review that I did together with Stefan Moritz. Maybe some of you know Stefan Moritz. He was in Vietnam last year. He is the developer of mindfulness, of metacognitive training, an amazing guy. We did this with our PhD students, a large meta-review, meaning we aggregated all data for mindfulness, and we could now show that there is effects on negative symptoms, on positive symptoms, general symptoms, affective symptoms, social functioning, but for cognition, the evidence is not so clear. Okay, so we now know we have a solid evidence base. Now I want to show you very practically how you can now use mindfulness. This is a model that we have been creating. It was based on the work of Paul Chadwick, who was a pioneer in the field of mindfulness for psychosis. Let me go through with you this from a very practical view. Okay, we talked now about evidence, and let's go on a very different level now, the technique. So imagine a patient that has auditory hallucinations. So this person is hearing many different voices. And normally, when this patient hears these voices and he feels that these voices are not controllable, they come and go when they want, yeah, is that they negatively judge the voices that they hear. They say the voices are mean to me. They want to suppress me. They want to do me very worse. Yeah. And because they are this way to me, they are so horrible to me, the patient tries everything to avoid the voices. He tries to stop the voices whenever possible. Imagine such a patient on the ward or in the outpatient facility. I think you will know many of those patients. He wants to stop them every time. And he describes the process of stopping those voices like an everyday box fight. The voices come and he fights against them. He wants that they go away. And this actually is stressing him even more. He's more and more tensed. His body is attached. You know, he's like getting more and more stiff. And when his voices come, he gets angry and distressed. And you can imagine how this becomes a vicious cycle. And this vicious cycle is shown here. You have a psychotic experience. Yeah, you try to avoid it. You are not able to do it. You judge the whole time what's been happening to you. You ruminate, you confront, and you are trapped in this reaction pattern. This is a very classical example I know of many patients. Now, the idea of mindfulness is to move more to the left. And don't think about this like a dichotomous pathway. It's not that you either go this way or that way. Therapy is not a process, left and right and left and right and left and right, until the left part emerges more. You want to cultivate what's happening here. So what do you want to do? When you hear the voices, you don't want to fight against it. You just want to accept that voices are here. This sounds very easy. It is not. It is a form of attitude. It's like when you have a distressing thought or emotion, you maybe directly go on your phone or you watch something. Yeah. Sometimes it's useful, but not always. Sometimes it's okay to just perceive that you are afraid. Just to perceive that you have a thought that says you are not doing this good. This is very human. These are human experiences. And also sometimes voices are human experiences. It's also good to normalize them to an extent. This means you accept that it's there, doesn't mean you say it's good. Acceptance does not mean you say, oh, it's good, thank you that you are here. It just means acknowledging that this mental state is there and you don't try to come into a fight. By leaning towards the voices and accepting them and not judging directly that they are mean, that want to destroy you, you can cultivate a process of letting go. And this is the idea of the technique. So by repetitively doing this again and again and again, the voices lose their distress. So I had many patients after time of practice that said, yeah, you know, the voices are still here and they annoy me sometimes, but I try to let it more go. I try to understand voices come and voices go, like thoughts come and go. And you can feel in the way how the patient talks about it, you know, the process of letting go is cultivated. And if you think, oh, in voices, it's very difficult, I cannot imagine doing it, try it with an easy thought that you have sometimes. And it is a training, a cultivation, more and more, an attitude of awareness that all of our perception, feelings, emotions, thoughts are passengers. Yeah? Everything comes and goes. Love comes and goes. Joy comes and goes. Distress comes and goes. It is like this. It's not always the same, yeah, but you cultivate it. So I want to put a lot of emphasis on the attitude because this is how the therapy works. Okay. So this is now research that we have done on the wards with patients with psychosis. And I want to show you a little bit what the patients have now mentioned. When we did the mindfulness therapy, you know, and you have the core elements on how the therapy works. Patient mentions through qualitative research, so we interviewed the patients, that they are able to detach from thoughts and feelings. They are able to cultivate presence. They are able to have non-judgmental states. But at the same time, patient also mentioned that they ruminate, that they get lost in their thoughts and feelings, and that they judge. So this was a very nice outcome because this outcome exactly shows this. You go to the left part and sometimes you go to the right part. That's very normal. But the training of the therapy is to become more and more here on the left. You don't fail if you do this because it's a human normal reaction, but you want to be able to go more in this direction. So if you take this from today's lecture, I'm very happy. Okay. Patients mentioned that they see effects on their emotions, on their cognitions, on their symptoms. I will come to this. So what do the patients say? I bring you here some quotes. Patients, for example, say, by doing the breathing exercise, I try to see the symptoms as more than what they are. That is, to recognize that they are only a part of something larger within me, that are not always my symptoms, but much more than that. I think this is a very powerful statement because I think many of you know that many patients with schizophrenia, for example, call themselves schizophrenic. Yeah, or that we describe people with borderliners. In Germany, we say borderliner, you know? So this is, I think, a very stigmatizing word because it means it's a label. You just say pretty much the patient is just schizophrenic, but the patient is much more than that. It has schizophrenia, but it's also a brother, a sister, a father, a husband, a mother. So what I want to show you with this is a powerful process, what the patient has mentioned, of decentering, of realizing that I am more than my symptoms. The symptoms are important. The diagnosis has a lot to do with their own identity. But imagine those chronic patients, that are very identified with their symptoms, that have difficulties of letting them go. And this statement shows that after therapy, the patient is again able to see many more facets of themselves. And this is a process of metacognition, to realize my symptoms are only a part of me. They come, they go. And this is how it would then specifically look like in therapy. And maybe if you think, I cannot really relate to this to psychosis, I would invite you to do it for yourself. Do you sometimes have a thought or a feeling where you are very much identified with it, where you think, oh, this is very true, and this sometimes distresses you? Then just be aware that is only just a passenger, something that is along with you for a long time, but it does not only define you. You are defined by many, many more things.
Hello?
Hello? Okay, I think I can continue. I'm not sure if there's a question or something, but I will just continue. If there's something, feel free to hop in anytime. Okay. So when we develop interventions, I'm trying to make this short here, also looking on time. This is how we develop therapies. There's a couple of PhD students who are very eager in developing this. When we develop therapies, we just don't develop them ourselves. You see here patients with psychosis. We develop the interventions with them together. These are here different kind of yoga and mindfulness teachers. So what I want to say is, if we develop therapies, develop it together with affected people, because we can learn a lot from people who are affected, because we develop the therapies for them. It's very interesting to learn from them. What works, what not, how can we change therapy? And we also have to, I think, include further stakeholders, like, for example, mindfulness teachers, like yoga teachers, etc. So this is just more an emphasis on how to develop participatively interventions. So out of this work, there has come out a couple of treatment manuals that we have published. This is some work that I've created together with Erik Hahn, as I mentioned to you, that many of you know, who is an excellent psychiatrist in the field of psychosis. Many know of him. He's also a professor in Vietnam. So this has been work, and it's been very beautiful work, because I'm a psychologist, as many of you know, and Erik is a psychiatrist. And this whole creating of the therapy has been a work of psychiatry and psychology working hand in hand together. So if you're interested in this, feel free to write me anytime. I'm happy to send this to you. How does such a mindfulness therapy look like? Now we come to the real work. This is a group therapy you can deliver on the ward or in the outpatient setting. It goes for 4 weeks on the ward or 8 weeks in the outpatient facility. When you do it in the inpatient setting, you have weekly main sessions done by a therapist, but you have co-therapy sessions done by a nurse, social worker, or psychology intern. It's a little bit like dialectic behavioral therapy. Not so complex, but the idea to cultivate and train mindfulness a lot during your inpatient stay. You have opening rounds, you have psychoeducation parts, and then the big part is the exercise itself. So what I want to now show you in the upcoming slides, and I hopefully could show you before, is that mindfulness is an experience-oriented therapy. It's not a cognitive therapy. You don't have to understand this. It's not that you understand, this is how mindfulness works. No, I can teach you. You have to practice yourself, and by experiencing the state of letting go, by experiencing present moment, by cultivating it, you facilitate the therapy. This is very important, because there's much evidence showing that the more experienced the therapist is themselves in mindfulness practice, the better is the therapy outcome. Okay, so you have therapy delivered this way. You have different focuses in the therapy that we have created. You focus on breath in the first week. You focus on your senses in the second week. You focus on the process of letting go, decentering, metacognition on the third week. And then the last week, in the fourth week, it is all about your body because it's a mind-body therapy. Okay. So this is how a classical therapy looks like. This is at the Charité, the ward of psychosis. You see here, we sit in a circle. We sit in a circle. The therapists are on eye level with the patients. What I mean on eye level is we are not seeing ourselves as higher or that we are teaching something. It's more that we are conducting the group together. We are experiencing the states together. If we do an exercise, we do it with the patients together. We share. I share as a therapist if I have a thought that I'm anxious or that I'm stressed and I realize this in the exercise, I share it with my patients. They should experience and understand that these are all very human and natural processes that we all endure. Some more, some less. Okay, we are not more than 6 patients and we are 2 therapists. So if actually someone really has worsening, which can happen, it can happen in every therapy, we can focus on this patient individually. How does such an exercise look like? I want to show you a very simple exercise that you can do yourself or you do with your patient. And I'm going to do this a little bit quicker. Please excuse me due to time. The idea, it's called the 3-2-1 exercise. So you sit down and you tell yourself, you can do it now with me. Tell yourself 3 things that you are seeing right now. I see, I see, I see. Now you close your eyes. I hear, probably my voice. I hear, maybe something else. I hear, and name what you hear. Now go into you within. You say, I feel. What do you feel right now? I feel, I feel, I feel. And now you open your eyes and you say 2 things you see. I see, I see. And I will continue now, but it's nice that many of you joined. You go down to 1. And when you do this, try it later again one more time, you will be more in the present because you have activated your senses. Now you can make the exercise more complex. You can make 5, 4, 3, 2, 1. Or in psychosis, I do a lot 3, 2, 1 because it's less complex. But again, back to my first slide, you can make it very simple. You can make 1, 1, 1. I see, I hear, I feel. Just a tiny moment of presence. So when I worked a long time in the outpatient facility, together with Tamta, who was heading that department for that time, it was a very nice time with Marco Zierhut. Maybe some of you know him as well, Dr. Zierhut, who visited Vietnam as well. I was sometimes seeing 12 patients a day in the outpatient facility. Every 30 minutes, a patient. I have to say that was quite a lot. So sometimes after those sessions, I felt quite exhausted, but I had the next patient. The clinic can be very hectic. So I tried there to cultivate it myself. Every time a patient left my room and I knew I have to see the next patient in 1 to 3 minutes, I said to myself, 3 things I hear, 3 things I feel, 3 things I see, 2, 1. This gave me a moment of mindfulness. I came back to myself. I reflected how my contact with my patient before was, if there's something important. I asked myself whether I need something, maybe a glass of water, because the clinic can be hectic. It's good to think about yourself, be compassionate. And then I opened the door and took the next patient in. I'm giving you this as an example to show that mindfulness doesn't need to be something exotic that you just do in very specific moments. You can cultivate it everywhere. When you walk from one ward to the other, sometimes we walk very stressed and very quick. That is okay. Sometimes clinic is like that. But maybe you take a moment of this walk and just try to feel your feet and come back to yourself, because a day can be very stressful and full. So it is about cultivating many moments in which you create presence. This is the idea. I come back to the exercise in the group therapy. This is now an important process because this is one of the key aspects of the therapy. You just don't only do an exercise, which is this here in the middle. You do an exercise that the therapist facilitates. It goes for 10 minutes. So if I would do a workshop with you, we would do this more extensively. But you do an exercise for attention, breathing, the body. And once you are done with this exercise, now comes the important part with the patients of psychosis. You reflect on what you have experienced. So the middle here is your own experience, your individual experience. But now we come into sharing in the group what you have encountered. So maybe a patient, you ask them, what have you noticed? What has gone through your mind? It's always open questions. You don't lead. Yeah? But you ask the question, what did you notice? And the patient maybe says, I noticed that I became delusional. I got paranoid thoughts. And you acknowledge that, you validate, you think, oh, it's good that you realize that. I see there's a paranoid thought. How did you encounter it? How does it feel? And the patient says, yeah, I felt there's a paranoid thought and my body got stiff and, I got tensed. Okay, you felt it in the body. What happened then? The patient said, yeah, I just realized that there is this paranoid thought. I listened to your voice and I continued, and this paranoid feeling flew away again. Okay, you see, the patient describes what they noticed. We don't judge. The patient accepts that the state comes, and we normalize it. We explicitly discuss it without criticizing what's been happening, and the patient learns to let go. It's a very simple formula that I'm describing. Now you ask the next patient what they have experienced. And maybe this patient has experienced the same thing, because many patients with schizophrenia are heavily stigmatized. They have seldomly the room, a non-judgmental room, to share what's happening within them, because we believe that their symptoms are often very different from normal experiences. This is called the othering phenomenon. But giving a room in where you can share what is happening within you is a very healsome process. So all patients are encouraged to share, but very important, they don't have to. If you have a patient that says, I don't want to share, you say, thank you very much for telling me this. It's totally fine. It's nice that you are here. I will give you another example of my clinical work. So I did a group therapy with 5 patients with schizophrenia. 4 of them were male, and they were very skeptical about the group. So we did the first half an hour, getting to know each other, talking about mindfulness. We did the first exercise. And then I asked here the patient at this stage, what did you encounter? What did you notice? If you want to share. The patient looked at me very critical and said, I don't want to share. I said, okay, thank you very much for telling me. I appreciate. I asked the next patient, so would you like to share? Patient says, no, I don't want to share with you. I don't know you. So, okay, you see, it's a very paranoid and mistrustful situation. As a therapist, I said, okay, it's fine. This is a part of the process. I asked the third patient, would you like to share? And he said, no, I don't want to share. I don't know those 2 guys. I'm sitting in this room group. I'm very critical. No, I be very honest, I become a little bit stressed. I thought, will they share something with me? We are here in group therapy. But now comes the process of your own mindfulness capacities. I said to myself, I realize that I get stressed, but this is the part of the process. It's okay. Let's just be there. Let's just be present and listen and give them room for their mistrust. So just waited a couple of seconds. And then one of the first patients said, well, I don't really trust you all. I'm a little paranoid, but you all feel the same. It seems that we all feel the same. And then they start laughing. So they felt very connected in their way of symptoms. And then the other patient said, maybe if we all feel like this, we should speak with each other. And it suddenly became a very joyful moment. And I like this situation a lot that I encountered many times. Maybe as therapists, we judge the situation. We don't want trust, mistrust, etc. But if we are just present and appreciate that also these feelings can emerge, there comes unity because these patients experience all of those symptoms: mistrust, paranoia, delusions, hallucinations, etc. Giving them a room of understanding that many feel this way can be very healsome. Now comes the third part of the therapy. Now we have shared this. We ask them how this can now help them in their general life. So the experience you have now made in the group, that you sometimes are mistrustful against others, how can this help you in your everyday life? For example, those patients then started to say, I mistrust people in general more. Okay, it's good that you realize that you are thinking this way. But how has this challenged you in your life? Yeah, they stopped watching football. They stopped going to friends or meeting people. So they learn that these symptoms have consequences for their everyday life. And their values are different. They want to reconnect like they did in the group, as I showed you in the example. So by that, we are speaking about the general values of their life and how the experiences of the group and how their single experiences can influence their general life. And this process that I've now talking with you in depth
we have
is
10 minutes.
Oh, 10 minutes. I can be quick. No worries, no worries. I'm going there.
Yeah.
It was for me important that we go through a very practical process that you can resemble more. And here I'm showing you many questions that you can then ask to facilitate the process that I've mentioned to you. Yeah. But in the end, what I wanted to show you is that this is practically how you do it. Because if we just gone through the questions, maybe this would have been more abstract for you. So collecting observation, reflecting the experiences, understanding what it says about your mind, and transferring these experiences into everyday life. This is the process from the group therapy. So there is a small video that we have done with Arte together. And I show this because you don't have many group therapies of patients with psychosis online. If you go on this link, there is a 1-minute snippet of one of our patients that show in the group how they get paranoid, how they do a breathing exercise and can let go of the paranoia. This is why I'm showing you this. If you Google Arte schizophrenia, you will find it if you're interested in it, okay? Because this makes it more practical. So what I want to show you is, if you do mindfulness with psychosis, the exercises need to be short. Think again of the beginning of the lecture, not mindfulness in the sense of a retreat, of an app. It is in a clinical setting. Minimize periods of silence. As a therapist, every 15 seconds, I say, I'm here, I'm supporting you, we are doing this exercise together. Do small therapy groups, not too many patients, not 12, not 14, and you need to be experienced in mindfulness yourself. It's not something you teach, it's something you cultivate. And I hope with the past slides, I could show you how you can cultivate yourself such an attitude more and more, because you will have it yourself already. We all are mindfulness to a certain degree, but it makes the therapy more effective. Here, I show you the mechanism summarized how mindfulness works. You increase awareness, you increase perspective shifts, which is theory of mind training, metacognition, which is important in psychosis. You train a not judgmental attitude. You train self-efficacy, and with this also acceptance. There is here a practical example. Here, a patient who came to the group and she felt very shameful about her diagnosis. And every time we did these exercises, she had feelings and thoughts that she's crazy, that she's worthless. And you see, these are very judgmental statements about yourself. If you are very fused, cognitive fused with these statements, it can lead to much distress. So mindfulness helped her more and more to recognize these thought patterns, these feelings, let go of them, and train a new relationship with yourself. I talked a lot about effects, and I have 8 minutes if I see it right. So I want to talk about shortly the negative ways. Be attentive that people can have fears and concerns about mindfulness. Mindfulness is, in a clinical sense, not a training of relaxation. It's a training of coming to the present. By being more and more present, it can happen secondarily that you become more relaxed. This is okay. But if you think I have to become relaxed, this is not the aim of mindfulness, because many patients don't become relaxed if they realize their thoughts and then they think I have done it wrong. But this is not the aim. Mindfulness itself is aimless because it's just perception. But by cultivating it, you can become relaxed. This is a nice side effect. If you have limited experiences yourself, as a therapist, it's important to be attentive, get good supervision. Patients can have the fear of losing control by closing their eyes, for example. Let them have open eyes. It's totally fine. When patients are very much focused on the outside, delusions, try to make inner mindfulness exercises. How do I feel within? If I have a lot of bodily experiences, like bodily hallucinations, I'm very much within in my attention, try to get them outside. How does the bird sound? How does the tree look like? How do I smell the air? Yeah, within mindfulness and external mindfulness can be very helpful as a technique. Okay. So I shortly want to show you a couple of studies. This will be quite quick. We showed here through our group therapies, you see 4 weeks of group therapy, that always before the therapy, patients were very stressed. After therapy, the stress was less. The symptoms were more before the session. Afterwards, it was less. You see across all sessions, it goes down, down, and down. It shows the therapy is well accepted. It leads to lower stress. So we did some very nice work together with Dr. Marco Zierhut that you know and our team. I want to just show you where the field moves toward. Just a small piece of science. You can now augment mindfulness therapy with intranasal oxytocin. This is called an augmentation therapy. Before the mindfulness therapy, you give them oxytocin. And what we could show is here, the group that get oxytocin in black, you see this compared to the control group, had even lower negative symptoms afterwards. So this is a very interesting showing of how you can couple biological interventions like oxytocin with group therapy. And it shows to the beginning that I said how psychiatry and clinical psychology can work hand in hand together to develop better therapies. I come to my last 2 slides. I want to talk about side effects because we come back to the beginning. You remember I started with saying mindfulness is a trend, and in the society, many people talk about it. Every hype, unfortunately, has a counter hype. For many times, I know people said mindfulness is a panacea. It has no side effects. It always leads to bettering and improvement. That is not true. Every therapy, if it works, has side effects. That's very normal. You just have to be attentive of the side effects. So here you see a lot of German newspapers now speaking about the risks of meditation. And this is a counter hype. As evidence-based practitioners, we are interested in effects, side effects, and adverse events to give informed treatment. But if we talk about studies, we have to understand what is a side effect. And this is a very good paper of Linden that shows not every adverse event that happens in therapy is related to therapy. If I group a therapy and, for example, my father is injured or becomes sick and I get worse because of it, because of course this does something with my life, it is not caused by therapy. Yeah, it is external. If I'm in therapy and I have problems in my relationship due to other reasons, not related to therapy, and I feel worse, it's not related to the therapy itself. So, but a lot of things can happen due to therapy. I do a therapy, but I do the therapy correctly. Then it's a side effect. And it's very important. Every therapy has a side effect. That's normal. Pharmacotherapy has side effects as well. Psychotherapy has the same, of course, because it works. But if the therapist does it wrong, then it's a treatment error. And you have to think, how did this treatment error happen? Because of unethical behavior? Because of technical error? You see, there are many reasons here why an adverse event can happen. It's important for us to be informed, why did the adverse event happen? because based on that, we can make a decision. If, for example, in pharmacology, side effects are very strong, and it is because of the medication, we think maybe we should decrease the dose, or we should stop the medication, we should try something different. This goes for psychotherapy as well. If I have a psychotherapy that has a lot of side effects for a patient, maybe I have to stop it, I have to change technique. And it goes the same for mindfulness. You see here, psychotherapy has many, many, many side effects. I make you here a list. I think this is important because we speak a lot about side effects of pharmacology. We have to speak about side effects of psychotherapy as well. But here is the large evidence that shows cognitive behavioral therapy has side effects, psychodynamic therapy has side effects, and I showed you here 2 papers. Mindfulness has side effects as well. But on average, these all therapeutic interventions have the same side effect prevalence. The amount of side effects are the same. The specific side effect is different, but in general, they have all the same side effects. So what I just want to show you is, beginning to the first slide, we have to understand what kind of mindfulness therapy we are delivering, who does it deliver, for which patient it is suitable and for whom not. And I showed here in this paper that there is an amount of patients that get adverse events through this therapy. And we have to be attentive for them. And if you realize a patient suffers more from this treatment, then we have to stop the treatment. But at the same time, there is a big portion of patients that profit from this therapy. You can make evidence-based decisions together with the patient for whom it will work and for whom not. This is what I wanted to show you. So I come to my last slide. Mindfulness can facilitate self-awareness. It can facilitate emotional regulation, social awareness, and relationship management. These are the processes that it facilitates. It's individual, but it works in patients with psychosis. And I know you have been having a long day. So my question is to you, do you take time for yourself for mindfulness in your everyday life? How do you notice that you are doing this? What prevents you from taking a moment of mindfulness for yourself? And how would such a moment in your life look like? I mentioned to you a small fragment of my life when I see patients, for example, where I put it in. And you have many of those islands in your day where you put in small parts of mindfulness for yourself, because in the end, it is just an attitude. It is how you perceive the world. So with that, I thank you for your attention, also for the organization. I hope it worked well with some technical issues, but I think we solved it well together. I had the privilege of presenting you a lot of evidence that we have created, but this has been a teamwork. A lot of people have been working on those studies, so there's a big applause to the team that is working on it. You see here psychiatrists, psychologists, social workers, and other people. This has been a collective effort. I'm very thankful for the team that has been working on this. I gave you here an appreciation of the funders that have been funding this. And if you're interested, I always like to share 3 books to dive into this further. So this is a very classical book on clinical mindfulness, and I think it's good to be informed about the clinical dimensions. This here is just a drama. I like it a lot. It says Mindful Killing. It is a humorous way, a satire way of talking about mindfulness. And I think it's nice to understand these dimensions. And then there is a very nice book of Hartmut Rosa, a sociologist who criticizes the concept of mindfulness in Western civilization. And I think if we are aware of the effects, of the side effects and of meaning of mindfulness in our society, then I think we can become informed clinicians. And with that, I stop my sharing of the stream. I hope this works, and I'm looking forward for questions or discussion. Thank you very much.
Thank you so much for your presentation. It's wonderful. And I think that we have now the overview about the mindfulness, the evidence-based mindfulness. We want to stress really evidence-based mindfulness. And I like your slide to say, yes, that is a many effect, but also we have to take in account the side effect. And that is, I think, is also important to keep in mind as the therapeutic, scientific in the field of psychotherapy. Yeah, that is, we do a mindfulness, but it's important also to think mindfulness or the evidence-based mindfulness. That's why our associations for psychotherapy or psychotherapy, as well as Professor Đặng Hoàng Minh and I, we want really to put and also to stress the evidence-based psychotherapy. Thanks a lot, Karen, for this wonderful presentations. I know we have some issue with the technical at the beginning, and so that is we lose a lot of time. So if you have any questions and comment, please write into the chat, because we don't have now time for the question and answer session. But I think I also want to stress that is Professor Karen Berger show that is the high evidence of the evidence-based therapy by psychosis. But please not forget that the patient use the medication also, but parallel to the mindfulness therapy, not only the psychotherapy. It's very important to keep in mind that it's a psychotherapy and mindfulness-based therapy is something like add on to the treatment as usual patient with psychosis. Tức là các anh chị lưu ý dùng chúng tôi là giáo sư Karen có chỉ ra là cái evidence, cái gọi là bằng chứng của hiệu quả của mindfulness trong điều trị bệnh nhân tâm thần phân liệt hoặc là bệnh nhân có rối loạn loạn thần. Nhưng quan trọng là bệnh nhân vẫn sử dụng các cái thuốc chống loạn thần và vẫn sử dụng các cái biện pháp trị liệu bằng thuốc, chứ không phải chỉ riêng mindfulness therapy. Đấy là cái điều mà tôi cũng muốn nhấn mạnh thêm. Có các anh chị nếu mà có thời gian có thể điền cho tôi cái đánh giá của cái buổi ngày hôm nay. Chị Minh có vài lời chia sẻ cũng như là kết thúc cái buổi ngày hôm nay được không ạ?
Vâng, cảm ơn Tâm. Như vậy là mình không còn thời gian cho QA nữa đúng không Tâm?
Dạ vâng. Em chỉ sợ mà chắc là mình hoặc là mình sẽ còn để em sẽ hỏi anh Karen Berger. Karen, do you have a little bit more time, because it's so
no, of course.
I think it's about 10 minutes is for you. 10 or 15 minutes, because it's so interesting.
Of course. I'm happy to discuss. Yes, go into discussion. I'm happy to be here, of course. Shoot out.
Thank you. Như vậy chúng ta đã nghe cái bài trình bày rất là thú vị và nhiều thông tin mới của giáo sư Karen. Thì bây giờ thì xin mời các anh chị là chúng ta nếu có các câu hỏi gì thì chúng ta có thể là phát biểu. Chúng tôi khi nãy có thấy một số các anh chị có đánh vào cái chat, nhưng mà tại vì nó trôi đi nên là những anh chị mà nãy có đánh vào chat thì có thể là bây giờ mình cũng có thể phát biểu luôn. Vì thời gian không có nhiều, chúng ta chỉ có 10 phút thôi, nên là các anh chị chúng ta cứ mạnh dạn phát biểu ạ. Mạnh dạn có các câu hỏi. Vâng, hình như có anh Vũ phát biểu đúng không ạ? Anh đang mute.
Will someone translate for me, or how are we handling this?
Hình như anh Vũ đang nói bằng tiếng. Sorry.
No problem. Or just ask the question in the chat, and I'm happy to use the translator. I will translate into German and then answer if this is fine. I don't know.
Vâng, anh Vũ, anh cứ trao đổi bằng tiếng Việt cũng được ạ. Tôi có thể dịch luôn cho giáo sư, bởi vì không biết bạn Vân có chuyển sang cái kênh này không?
Actually, I didn't have any questions, but just a quick question to Karen. And is it possible to empower the patients do it, the mindfulness procedures or the exercise at home on their own, or they have to do with the guidance by the expert?
Yes, this is a very, very good question. So this is a long debate. If you do mindfulness, for example, with depression, or borderline personality disorder as a skill, for example, a lot in borderline, you want them to practice it a lot at home. I think as a therapist myself, I always tell my patients, the real therapy does not happen in the session. The real therapy is outside the session, because you want that the patients are able to, whatever they learn in the therapy, to do it in their everyday life, right? This is where the real therapy lies. The therapy is just a facilitator. But in mindfulness with psychosis, you have to be careful, because you can invite them. I always use the word invitation, because it's very important to show the patients you are autonomous. You have the right. You decide what feels good for you. And then I would ask them maybe, what do you think? How can you take this into their everyday life? For example, a patient says, I have a dog. I walk with the dog outside. I will sit sometimes with the dog outside on a bank and just watch the sky or listen to the trees. Okay, how would you do that? Describe me. And then he describes how he sits with the dog, and he said, what happens if the patient describes it to you and you really listen? You listen attentively. You become to the same state, right? You imagine you are with him there. You are sitting there with him together, right? This makes a very mindful description. So then it's a good thing, and you could follow that up. If the patient says, now, I feel forced now because it's a homework to sit every day at home and do 10 minutes of meditation, yeah? I would not encourage to do that. I would let the patient invite themselves to find out what mindfulness means for them in their everyday life. I don't have an imagination what is good for them, because it's good for everyone differently. But to cultivate this attitude in their everyday slowly, and to progress in therapy together. Because you want to, of course, ask them, when you were sitting there with the dog and you were listening to the tree, what happened? Maybe the patient will tell you, I felt very stressed. A lot of thoughts came in. I became angry and tensed. Maybe it's good to pause. Let's work on this together. What does this mean? It can be beneficial, but it can also be stressful. And this is more the idea in psychosis. Yeah. No forcing, no homework in the sense of you need to do it, more cultivation of processes.
So also I have the question that is or not question, but the notice that is a mindfulness. We need to be very careful for patients with psychosis or overthinking, so very severe overthinking, and the patient. What we have to do when we treat the patient with the symptom of psychosis and the severe psychosis symptoms? That is one question.
Yes. This is a very important question, and I hope I could have pointed it out, but I'm happy to take this up one more time, because I don't want to have any misunderstandings. So all of psychotherapies in psychosis work best if patients take medication. It's always additive, as I showed in the beginning with the guideline. Pharmacotherapy is one pillar. Second pillar is psychotherapy. I sometimes criticize my psychotherapist colleagues if they say psychotherapy but not pharmacology. You have to give them pharmacology. But I criticize my psychiatrist colleagues if we just give pharmacology and not psychotherapy. Best combined together, has very good evidence. We can treat psychosis nowadays very good with strong effect sizes. And not only psychotherapy, psychosocial interventions as well. Occupational therapy, social work, all of this. It's a multifaceted treatment. Mindfulness is one fragment. It is a powerful fragment, but it's not the only one. This is, to me, very important. Now, when the patients are severely psychotic, what I mean with this is that they are not able to take part in the group therapy. I would not encourage you to give them mindfulness therapy. If a patient cannot take part in general in any group therapy, they are too agitated. We have to use different treatments in that state. But once you feel this patient can take part in a group therapy in general, they can also take part in a mindfulness therapy. But again, only if the therapist also feels secure enough to give this room. Yeah, I would not experiment if you don't feel well. Good therapy needs good supervision, yeah, and own training, of course, as well. because we talked about adverse events, right? I showed you if you do the therapy wrong, it can have severe consequences. It's like if you give pharmacology wrong, it has severe consequences. These are powerful agents, okay? But let's say you're well trained and you give the therapy right. You can also give it to patients that have psychotic symptoms, moderate to higher symptoms, but very severe symptoms in the sense of I cannot take part of a group therapy. I would not recommend to give them mindfulness therapy. I think then it would be useful to do very short therapy sessions, 10 minutes, 15 sessions, going outside, taking a walk, right? You know this. Schizophrenia is very heterogeneous. Yeah. So I think this is important. But I also had a lot of patients that had more symptoms. I felt very secure with the therapy. So I went outside with them for a walk, 10 minutes. And while we worked, they were quite delusional. We sit down on a bank, and we just look together at the sky. Or I let them explain what they like. Activate the resources of the patient. Yeah, so I treated many patients that were young, male, so they like football. Okay, that's the classic thing. Okay, what do you like about football? Yeah, I like when I watch the players and the shooting, Cristiano Ronaldo, Messi. Okay, so you can watch together with them something. Yeah, and they describe how they perceive this moment. Be creative in how you use it. As I said, informal practice. It's a way of how we perceive, how we reconnect. And we can talk about something, or they play music. Okay, many patients they've done music before. I like metal music. Okay, so we talk about music. We listen together to music. We can listen to music together. Take out your phone, listen to music together. Just listen. What does it make with you when you listen to the music? Yeah, then you are in the presence. What I want to show you is we can do therapy much more low threshold and be creative in just facilitating the processes of being attentive.
Cảm ơn giáo sư Karen Berger. Tôi cũng muốn nhấn mạnh lại một lần nữa, đây là chúng ta cùng điều trị với các bác sĩ tâm thần và chúng ta phải có cái sự luyện tập ở trong đó. Bởi vì là điều trị những bệnh nhân nặng thì chúng ta cần phải có kiến thức để tránh được những cái tác dụng phụ. Bởi vì như giáo sư Karen cũng một lần nữa nhấn mạnh là các cái tác dụng phụ. Các anh chị chú ý là chúng ta cần phải có những cái luyện tập trong đó và cần phải biết lúc nào sử dụng cái biện pháp gì cho bệnh nhân tâm thần phân liệt. Maybe the last question is about the negative symptoms, because you show the effect on the positive symptoms, but the negative symptoms is also the question. How about the negative symptoms? Maybe only the short.
Very, very good question. So the German guidelines, they are very strict before they give an evidence grade to psychotherapy. So I showed you there are 15 trials in the field, and most of those trials in the beginning focused on positive symptoms. That's why you have now the evidence grade for positive symptoms. We are doing right now a meta-analysis only for negative symptoms. And I'm quite optimistic that you soon will have the same evidence grades for negative symptoms, but it's not there yet. Very important, it's not there yet, but it's going there. There's a study from Taiwan who showed this in more than 300 patients. I do personally think from my own experience that there is an effect on negative symptoms, especially in chronic schizophrenia, but you have to give the group therapy at least for 12 weeks. So the guidelines are strict. Next year, we will re-evaluate the guidelines. Maybe then negative symptoms will be there as well. I showed you one slide with our own meta-analysis. There you see you already have the effect. I will post right now another meta-analysis into the chat where you will see it is a little bit older and there is more evidence nowadays, but it shows you that mind-body therapies have effects on negative symptoms, but the evidence is more slowly building. This is a little bit the important point. I hope I could have addressed this. I think we need 3 more years and then the evidence will be more clear. Important. The evidence on negative symptoms in psychosis is primarily through group therapy. When we do positive symptoms, whether you do individual or group, it works both well. But we see the power of group therapy, which I think is quite nice to see.
Thank you, Karen.
Of course. Thanks a lot for the very, very nice questions and your critical remark. Also, feel free to give critical feedback. If you have questions, write me an email anytime, no problem. I'm happy to discuss.
Thank you, Kerem. Thank you, the organization. Thank you, the interpreter. Thank you, Hà Luông, Louisa, Eileen Ho. Thank you, Professor Đặng Hoàng Minh. And also thank you, Professor Võ Văn Bản, for all the organization and all the many organizing staff to make this workshop happen. I would like to thank all of you and see you in 1 month. If you have any question and comment, we will try to optimize also the process, the organization, and we hope to see you next time. See you soon.
Thank you.
Bye-bye. Greetings to
Thanks,
Vietnam.
bye-bye.
See you soon again. Bye-bye.
Thank you very much. Yeah.
Thank you very much.
Bye bye.
Recording
Bye-bye.
stopped.